𝗩𝗡𝗡𝗡 Academy Vaginal Surgery Masterclass. Today's topic is vaginal surgery in special population. Adapting the technique for the elderly, obese and nulliparous. In this, we will learn what techniques we should adapt for elderly frail patients, what should be the operating safely in the obese patients, how to preserve fertility and coital function when needed, and managing the comorbidities that raise the surgical risk, and choosing the anesthesia wisely by patient profile. So why this matters? One technique does not fit all. 12% lifetime risk of prolapse surgery for any women, increase the risk, rises sharply with age, obesity and comorbidity. The vaginal route is often the safest option for these patients, and if approach is adapted. Elderly patients, preoperative consideration about the cardiac and pulmonary reserve assessment, cognitive status and consent capacity, and frailty screening, not age alone. So elderly patient, why vaginal route suits them? Because no abdominal incision, faster mobilization, it lowers the blood loss and shorter the operative time, and it is well tolerated under general anesthesia or the regional anesthesia. Elderly patient anesthesia choice, regional specially preferred over the general. It avoids the airway manipulation and post-op delirium risk, and it allows early feeding and mobilization. Elderly patient, colpoclysis, a definitive option. For frail patients who no longer desire the coital function, short operative time and very low morbidity, high success rate and high patient satisfaction. Consent before colpoclysis, explain permanent loss of vaginal intercourse capability. Confirm this is not desired now or in future, and document the discussion early. Now the obese patient. Obese patients have added surgical risk. They have the higher rates of wound and pelvic infection, the reduced visualization and a limited access, and higher venous thromboembolism risk. So the vaginal route is very good for the obese patient, and that helps here because it avoids the abdominal wall complication entirely, no pneumoperitoneum ventilation challenges, and lower the wound infection rate than open and laparoscopic routes. Obese patient positioning and exposure, steep lithotomy with adequate padding, paniculus retraction tape or dedicated retractors, and longer instruments may be needed. In obese patient, VTE prophylaxis, mechanical prophylaxis for every obese patient, pharmacologic prophylaxis if risk factors stack up, and early immunization is protective, mobilize on the day one. A different calculus, uterine sparing in a nulliparous patients. Uterus sparing option should always be discussed. Fertility and future pregnancy plans and shape the approach. Rare in this group, usually a structure and connective tissue defects are there. So in nulliparous women, uterine sparing option, sacrospinal cystopexy preserves the uterus. Comparable success rates with a hysterectomy-based repair, and it's preferred when the future fertility is desired. Technique, the preserving coital function, avoid over-narrowing the vaginal canal in repair, calibrate the introitus intraoperatively, and discuss the sexual activity goals before choosing the technique. Comorbidities with these patients can be there, like diabetic patient, optimize the glycemic control before elective surgery, higher wound infection and delayed healing risk, and tighter perioperative glucose monitoring. In a cardiac patient, vaginal route reduces the hemodynamic stress versus laparotomy, regional anesthesia often preferred, and cardiology clearance for significant disease. The anticoagulant patient, the patient who are in the anticoagulated patient, the coordinated bridging with the prescribing physician, meticulous hemostasis, vaginal route allows the direct control, and individualized timing around the thrombotic risk. In special cases, the radiation exposed pelvis, fibrotic tissue planes, dissection is harder and riskier, higher risk of fistula formation, consider referral to the high volume center. The patient with a prior mesh, which is nowadays is not so common, review previous operative notes before planning, anticipate distorted anatomy and dense scarring, and have exposure and extraction techniques ready if needed. If the patient is virgin or adolescent patients, rare indication, usually the congenital anomaly, preserve hymenal and intra-aortal anatomy where possible, involve family, patient in every decision. Inform consent across the populations, tailor the discussion to the patient's goal, not to the script, address fertility, sexual function, and recurrence risk, document population-specific counseling clearly. Building the right surgical team, anesthesia input early for the high-risk patients, cardiology, endocrinology involvement when it is indicated, a clear escalation plan before you start. So outcome across the populations, equivalent success rates for the vaginal repair regardless of the BMI, lower the complication than the abdominal approach in the elderly. Postoperative care adjustments, early mobilization targets for early and obese patients, close glucose monitoring for diabetic patients, individualized follow-up interval by risk profile, and when to refer, complex mesh complications beyond your comfort level, severe cardiopulmonary disease needing a specialized care. When in doubt, a second opinion protects the patient. So clinical judgment, the pearls and pitfall. The pearls are frailty, predicts risk better than chronological age, ask about sexual activity goals, don't assume. The vaginal route is often the least invasive option. The pitfall is choosing colpoclysis without confirming the consent fully, overlooking the VTE prophylaxis in the obese patients, and assuming one technique fits every body habitus. So the key takeaways, summary and a closing: frailty, not age, should drive risk assessment. The vaginal route often serves high-risk patients best. Adapt anesthesia, positioning, consent to the patient. Preserve fertility and function whenever it is desired. And when complicity exceeds your comfort, refer without delay. Thank you so much.